sir.
Thank you. So the mitral valve has got a long history. It is the valve which sort of set the motion as far as echo is concerned. So it's got a lot of background behind it. It's a broad topic, so I'll focus on some basic and some key areas. Let's look at the valve itself. When you look at the valve, it is a complex or an apparatus as it is described. So it has the annulus, leaflets, you have the chordae, the papillary muscle, the left ventricle, and the left atrium also, since they are also involved in mechanisms which can lead to problems. So they're also sort of indirectly part of the apparatus. Now, a few important points as far as the valve is concerned in terms of anatomy. So one needs to know that there is something like a fibrous skeleton of the heart. So this is dense connective tissue which sort of wraps itself around all the four valves. But when it comes to the mitral valve, it is the thickest because it is the left ventricle which it has to support. This is something which one has to be aware. So this prevents overstretching of the valves and also acts as an electrical sort of a barrier between the atria and the ventricles. The next important anatomical point which one has to keep in mind is that there is something called as a central fibrous body here. So here you have the AV node, and you also have a little bit of the interventricular septum which sort of peeps around here, and then you have the right trigone. So this forms a crucial area, especially for the operating surgeon. So any pathology which is involving this area, one needs to highlight this in the report. Then the actual specimen. So this is something which we are all familiar. So just going through this. So you have the mitral valve, and then you can look at the chordae here, and then the papillary muscle. So it looks so different from what we see on the 2D and the 3D. Let's go a little inside the mitral valve. So this is from the left atrial side. You have the mitral annulus, which circles around the valve. And then from the mitral annulus, you have the anterior mitral leaflet and the posterior mitral leaflet. And what is very obvious is that this has got a large area, but less of connection to the annulus. So it is more mobile, while this has got more attachment and less area. So it is less mobile here. And then you have these small indentations, which are the scallops, which the anterior mitral leaflet does not have. If you go to the LV side, you look at the chordae very clearly here, fine, thin chordae. So, and then you have the papillary muscles. Then just one last look at the anatomy. So the important anatomy, which an area which one again has to note is that there is something called as the intervalvular fibrosa between the aortic valve and the mitral valve, specifically the anteromitral leaflet. So this is also called as the aortomitral curtain. And this is where a lot of pathologies happen. And the trigones, as you can see, this is how it looks like. So now that we know the anatomy, let us look at the approach. So the approach is to answer these questions. So taking a table from the European guidelines of 2017. So if one has to look at the valvular heart disease, there are a lot of questions which has to be answered. So from the echo point of view, we can look at how severe is it, what is the etiology to some extent, and we can also correlate symptoms in terms of severity. And also we can look at how we can associate and in terms of prognosis, in terms of intervention, in terms of especially asymptomatic patients. And also looking to see what type of surgery, what type of intervention can be planned. So this is how the echo can be helpful in terms of mitral valve. Now, there are three possible ways to assess the mitral valve. So one is by transthoracic echo, another one is the transesophageal echo, and the less trodden path is the stress echo. The transthoracic echo is a class 1 indication, and it is primarily to look at the etiology, severity, the hemodynamics, the prognosis, the timing. So this is in the early phase, in the initial phase. Then again, if one has to repeat echo, it is in terms of looking at when there is a change in symptoms of physical examination or in periodic monitoring of patients with this again as per the guidelines. T is in certain scenarios, like especially if you have a mitral stenosis and one is looking at an intervention, looking at thrombus, suspicion of infective endocarditis where the transthoracic echo is not contributing, and then you looking at mechanism for the valve dysfunction, which again TT is not providing, and then again to guide and monitor interventions. As far as exercise testing, it's very niche areas. So very still the data is sort of unfolding, but it's coming more and more into prominence. I have limited experience in this, but there are some institutes doing a lot of exercise testing. So again, this is to look at symptoms and its mismatch, look at hemodynamics and mismatch, and also to determine prognosis. So this is where exercise testing is concerned. It can be both exercise echo, which is preferable, and in some areas where dobutamine also can play a role. Now let us look at the methods. So methods wise, there is the M-mode echo, you have the 2D echo, and then you have the Doppler. So this is the mainstay, the backbone of routine echo as far as mitral valve is concerned. So we have now 3D, which is playing a big role, strain, which is sort of mentioned, but still has a limited role. M-mode primarily has got limited value only in certain scenarios, and these waveforms generally tell us some sort of an abnormality in terms of how the filling is happening, in terms of any pathologies. So primarily it reflects the phasic nature of the LV filling, but limited value. Then you have the 2D echo. So here again, it is very crucial, but it is window dependent. So good windows gives you good information. If not, you have to look at other modalities. And what information does it give? It gives you structural information in terms of the mitral valve apparatus and the chambers. Next is the Doppler, again, very, very crucial. So Doppler can be divided into color flow and then spectral. So it looks at flow abnormalities. It gives us spatial information in terms of the jet itself, presence or absence, and then multiple jets, in what direction it is going. So that is the advantage of color flow, while the spectral Doppler provides us information about gradients, velocity, pressure uptime, and so on, and many other parameters. So that's where the spectral Doppler provides us. 3D echo has been very, very sort of been a game changer as far as T is concerned. It gives you better spatial understanding of the anatomy, better understanding of anatomy. It has its own disadvantages, has its own sort of limitations, but to a large extent, it can be very, very helpful, especially when it comes to T. It can also give you good functional information in terms of the LV function. But what is important is that it is dependent on 2D images. So good 2D images provides good 3D images. Strain, there is the data are sort of continuing to come. Again, limited utility, but gives us information in terms of functional information. So this is an example of a severe mitral regurgitation, and this is a document from the ESCBI, and where they say that it is reasonable to do it. And where they say it is in terms of asymptomatic patients and severe primary MR, where there is borderline values when you have 60 to 65 decision making, also borderline LV and a systolic diameter in terms of regurgitation, in terms of decision making. Now, look at the views. So these are regular views, which you're all familiar. Beyond this, the key sort of point is not just look at the traditional views. One has to go and look at the off-axis views also. So one has to sort of adapt and be flexible if a particular view is not forthcoming. So one has to go a little away from it and try to get the off-axis views, and where we can get some additional information. So the mitral valve especially is a very, very eco-friendly valve, and that is why you get some excellent images, and these are the standard areas, the views which you see it. Now, I'm switching to T. So these images are intuitive, so they're almost like the transthoracic. So let's sort of look at how we can piece the anatomy here. So let's take the annulus first. So you have these terminologies. So depending on which view it is the medial lateral annulus, and then again in this 3-chamber, it is a posterior annulus, and then the inferior, you can look at the inferior anterior annulus. So the annulus can be sort of localized. And then one can look at the annular plane in terms of measuring the annulus, in terms of sizing it, or to look at any mitral valve prolapse, or for other reasons, in terms of various measurements that are now to be done in terms of mitral valve repair. So the annular plane is something which is very important. Then the leaflet itself. If you are going to write an echo report, and if you are going to be very specific, we have to be very, very careful in how we write it. So you have the atrial side of the leaflet, and you have the ventricular side, and then you have the margin, the mid leaflet, the base. So this is how we can localize it. Then we can look at leaflet segments. So this itself is quite extensive, so I'll just sort of go through it very quickly. So again, in the 4th chamber, you have the segments 2, which are sort of common to both the anterior mitral leaflet and the PML. And then you have the 2-chamber view, which gives us additional segments as far as AML is concerned, where AML is more prominently seen. And then the all-important commissure view. So this is where you get to see the commissures, especially when you have an obstructed lesion of the mitral valve, where looking at the commissures is very, very important. And this is the anterolateral commissure, which is towards this side. And then you have the posteromedial, again, away from the appendage here. And then this is typically the long axis view. So the segments, the A2 and P2 segments are seen here. So there are many variations which I'll not go into. Now, look, coming to the subvalvular apparatus. So we have to be a little more sort of, more detailed here. So let's look at the anteromitral leaflet here. So the anteromitral leaflet, if you look at it closely, has a chordae which comes and attaches here. So this is to the margin, so it is called as the marginal chordae. Then you have the chordae which attaches very few, not many, what are called a strut chordae. So this attaches to the mid segment. But what is important is the base of the leaflet does not have any chordae, and this is the clear zone. So this is how the anatomy of the AML is when it comes to the chordae. The PML, on the other hand, is chordae inserted throughout the length of the leaflet. So you have the marginal chordae, you have the mid chordae, and then you have the basal chordae. So that is the difference as far as chordal attachments to the PML is concerned. Now let's look at the pathologies. We have the regurgitation here. So when we are looking at a regurgitant lesion, it is important that we do a very systematic approach. So in terms of we have to go through in a methodical way. So the first and foremost is, especially if it is an elective and you have time on your hand, so we have to start with the 2D, and this is something which you have to go through, do a good 2D examination first, look for any structural changes, structural abnormalities, look at all the various parts of the mitral valve. So here is an example of a mitral valve prolapse, and then you have a vegetation here, a flail segment. So there are many things one can pick up here, and this we can sort of associate and correlate with the color and the Doppler as we sort of proceed with the study. Now, a very important message as far as color flow imaging quantification is concerned: eyeballing and trying to come to a severity is not accepted, so it is not there in the guidelines. And this is a study which very clearly shows that they have taken 6 patients here, 12 expert people, and they were all asked to see the same images again without, they were blinded to it. And the error ranges from 67% to almost, to that's as high as you can get it here. So it's very important that we don't go by the color image quantification in terms of severity. So avoid this. This is just for an initial impression or in an acute situation where we can utilize this, but not in a routine situation. So how do we do this in a more objective way? You have this time-tested old method of jet area, has its own limitations, so pluses and minus. So be very careful. It is not very sensitive. You have these various sort of numbers here. So one is just to look at the jet area. Another one is to look at both the LA and the jet area and do a ratio to it and see how the numbers stack up. So not very reliable, but again recommended as far as the guideline is concerned. Next is looking at continuous wave Doppler. So just by looking at this, the waveform itself gives you an idea. So it has got a broad sort of duration. It is parabolic. That is the initial impression. And then you can see that it has got high velocity. So that is the other one. And the density itself tells you the more denser it is, more severe the regurgitation. But again, it is very sort of not very reliable, because you can increase the gain by cranking up the knob and you can get into trouble. So not very reliable here, but you can use it. Then looking at the velocity and the shape itself, you can see that this is more V-shaped. It is of lower velocity. So this tells you that there is high LA pressure, severe MR. So these are sort of subtle points which you can incorporate. Now, one can use the pulse wave Doppler. So the pulse wave Doppler, just looking at the E velocity. So the E velocity, if it is in something like, if I can call it as a grade 1 diastolic sort of a pattern, that means that the MR is not significant at all. So straight away, you can clearly tell that this is not significant MR. But once the E velocity starts to increase in height, you can start to see that the regurgitation is going to be more and more significant. So this is moderate. And then you can, once it exceeds about 1.2, 1.3, some even take 1.5. So that means the regurgitation is quite severe. Then looking at the pulmonary veins. So the pulmonary veins, you have the S wave, which is taller than the D wave. And as the severity increases, you start to see that the S starts to decrease in size. And at some point when it becomes severe, it reverses. So this is decreased S wave, so it is blunted here, moderate MR, and here you can see that there is actual reversal, complete reversal here. So this is severe MR. So looking at pulmonary veins. Then you have the regurgitant volume, so you can do it the traditional way. You can do it by the PISA method. Can be challenging. It is sort of mentioned in almost all criterias. It takes a little experience, and you have to make sure that your technique is good if you're going to get an accurate number. The one which is sort of probably would be the one which you should be using in a routine way is the vena contractor. It is reasonably objective and fairly simple and quite reliable and robust. Just two views, both in the long axis as well as in the four chamber. And just looking at it, making sure that the technique is good, zoom it up, and then you get these fine measurements and use this, and you get the vena contracta. It cannot be used in certain scenarios, but that's how the technique is. Next is the much hyped and much sort of talked about PISA. In terms of real life, not very great, mixed results. So you need to have a good hemisphere. Only then the PISA does well. So when the orifice is not circular, then the PISA is not going to be reliable. So you have to be careful in terms of what anatomy you're dealing with. And if you feel that this is an anatomy where the orifice is less likely to be circular and more likely to be oval or elliptical, your PISA will not work, and it can vary also. So just keep this in mind. It is a little time consuming, but again, this is part of the guidelines, and this is how it is. So beyond this, we have the 3D echo. One can look at the valve pathology better in terms of chamber volumes. It can be quite useful, and also to look at the effective regurgitated orifice area. It's still yet to come in terms of the PISA of the 3D. Chambers, we have to make sure that both the upstream, downstream changes are analyzed in terms of its size, in terms of its function, and very importantly, what is the effect of other valves which are there, which is may be causing some impact on the various parameters. So one needs to factor that. And the all-important PA pressure is something which has to be done before you conclude it. Now, the other area where echo is useful in terms of regurgitation is in terms of interventions. So these interventions are very limited in terms of the way it is done in Asia. It is still not come in a big way, but it can be very, very helpful, highly dependent as far as the intervention is concerned. The echo is something which is the eyes for the interventionist. So this is something where it can play a big role. Then you have this Carpentier classification, fairly simple, fairly straightforward. So in terms of especially mitral regurgitation, you have the type 1 leaflet where you have the normal leaflet, and this is where the annulus dilates, but the leaflets are normal. So you need to sort of keep this in mind. And then you have the type 2 where you have the excessive mobility. Excessive mobility is nothing but prolapsing when you have the flail leaflet also. And then you have the third one is the restricted mobility. Restricted mobility can be both in systole and diastole. And this is in rheumatic heart disease. This is where we are most familiar. And the one where systole is the cause for the restriction, this is in the ischemic heart disease, the tethered PML. So this is the Carpentier classification. So just a brief look at some pathologies here. So you have the mitral valve prolapse, where how 3D sort of provides you some very crucial and precise information in terms of segments which are involved. And then again, echo useful in terms of acute MR situations. That's another scenario altogether. Because of lack of time, I'll not go into it. And then this is a case of ischemic cardiomyopathy. Now let me go into the stenosis part of it. So this is the other area. In stenosis, it's important that when we look at any valve which we look at possibly stenotic, we have to look at the mobility and look at the thickness. The more the thickness, the more thickened the valve it is, the more it is towards the annulus. That means it's not a good valve. More calcification, again, obviously not good. And then the subvalve also, as you can see here, a lot of calcification and involving the subvalve. So we have to be very careful. Not easy subvalve, but you need to look at views in terms of the long axis and then a little bit of off axis, foreshortening, and going off axis in the fourth chamber also. Opening of the valve is best seen, especially in the short axis, especially to look at the commissures, look at the calcification, which was not seen in the other views in a sort of on-fast way. And then the M-mode in one of the few scenarios where it can be helpful. So if you see the PML going towards the AML, that is a paradoxical movement. So that is very classical and very sort of striking as far as RHD is concerned, where there's commissure fusion. So this is one of the few areas where M-mode is useful. And then how do we sort of quantify it? So in terms of planimetry, you can go for a straightforward planimetry in terms of 2D, and then look at the valve. Has problems, can give you problems when there is calcification, can cause shadowing, and again the commissures may not be in the same plane, so it can vary. So the valve area can vary here. So a better approach is, if you have a 3D probe, you can just go for a biplane or an X-plane, and then you can make sure that you cut it at the exact moment, and you can get your valve orifices very precise and very accurate. Then you have the all-important and all-familiar gradients. So gradients are Doppler, and then they are sort of influenced by hemodynamics, so that we have to be very careful. So the gradients are important, but if we have to make sure that we don't sort of over-depend on to correlate with other parameters also. And then you have the mitral valve area, the pressure half time using this method has its own limitations, but this is again another routinely used technique, and this can also be used. Then the less used and possibly more of theoretical, I have never used, frankly speaking, here, the continuity equation, and then you have the PISA. So this is just for the sake of including it, I'm sort of including it. And then you have the mitral leaflet separation index. To some extent it works. So just by a simple measurement in the zoom view, both in the long axis and in the 4-chamber view. So just the distance between this tells us it's a very specific test, not very sensitive. So it can tell you that whether it is severe or it is mild. And this is useful, especially in quick scenarios or where your other parameters are ambiguous. So again, in terms of looking at stenosis, you look at the 3D where it can give you information in terms of the commissures, where the 2D can be a bit of a problem. Complex asymmetry of the orifices, 3D can be helpful. That is where the real sort of value is. And then you have the chambers in terms of assessment, and especially to look at the LA thrombus, the T would be very useful. And again, just like the leaky valve, the other valves impact also should be considered, and the PA pressure, as always, is very important. So like interventions here, you can see that it is very important as far as the mitral stenosis is concerned post PTMC. This is a scenario where you can see that it can tell us problems in terms of complications, in terms of success, in terms of guiding the interventionist. So this is where it is useful. So coming to the last few slides, again, obstruction stenosis. You have the congenital example here, and then you have the older age where you have the annulus which calcifies and can cause stenosis in a very small minority, but it is always there, which we have to sort of know about it. And then you have this so-called the pseudo sort of mitral stenosis, which sort of the large myxoma echo can be very useful here. And you can see that it mimics the mitral stenosis. And this again can be very valuable in trying to find out what is the pathology causing the mitral inflow obstruction here. So in conclusion, mitral valve is something which is very eco-friendly compared to a lot of other valves. It is very important that you go through a very methodical way, especially when you have an elective echo, and make sure that you go through the sequence so that without missing, and make sure that the multiple parameters are taken into account. And a combination of these parameters tells you in which direction your stenosis, your severity is going. And whenever you have ambiguous or you need incremental information, definitely look at T, 3D, and of course, additional other multimodality imaging options are there. So to my last line would be, is very useful in trying to look at the diagnosis and detecting the abnormality. And it can be very useful in terms of procedural planning, and also to monitor these patients post-procedure, or even as they sort of progress and you want to keep looking at the patients for long-term monitoring. Thank you.